Hello, I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the ice cream on your nose and sand between your toes primary care pod from Red Whale.
The primary care pod from Red Whale.
So grab your preferred drink of choice, your trainers or your dog lead, and here's what's bubbling up as we dive in search of our pearls for this month. Here's what's bubbling up this week. Potassium 6.1. What should we do? Processing blood results can feel like playing a game of Jeopardy. There are often a lot of normal no actions, but sometimes something potentially serious and even life-threatening can be lurking. In this week's Pearl, we share a GEMS, that's Guidelines and Evidence Made Simple, on assessing and managing hyperkalaemia in primary care. June was Pride Month, and in honour of that, we're sharing a Pearl that looks at some specific considerations for supporting LGBTQIA+ people with cancer. We'll consider screening, diagnosis, support when living with cancer, and beyond. Here's what's bubbling under for next week.
Have you ever had a patient ask you whether you think it's a good idea for them to take up vaping? E-cigarettes have been in the news again after a ban on the sale of single-use disposable vapes came into force on the 8th of June 2025. This government policy has been implemented in part because disposable vapes have been cited as a key driver in the rise of youth vaping. But can vaping be a positive thing for some of our patients? The story is nuanced, so we're going to unpack it. The back of my heel hurts. Approaching pain in the Achilles region. Long summer days and more outdoor sports activities lead to more MSK presentations on the triage list. Many of us have joints we feel less confident about, and the heel and ankle is definitely a common area people ask questions about on our MSK courses. We dive into Achilles pain.
So let's start off with our first Pearl of the month, and hyperkalaemia. Now, you're filing your results on a Friday evening and you see a potassium of 6.1. What should you do? Filing blood results can feel like a game of roulette. There are often a lot of normal no actions, but sometimes something potentially serious and even life-threatening can be lurking. In those moments, when we look in the notes, we hope that it's clear why the test was done. Thinking of that potassium of 6.1, we might feel very different levels of panic depending on whether the explanation in the notes was routine hypertension monitoring or gastrobug, diabetic, heart failure, CKD. Now, this Pearl is based on something a bit different, a GEMS on assessing and managing hyperkalaemia in primary care. Now, GEMS stands for Guidelines and Evidence Made Simple, and these are our flowchart summary documents. So this was a fairly quick one to read, and it took me 7 minutes and 45 seconds, enough time for a coffee and a banana.
Oh, those are high potassium choices there, Nick. Feels slightly dangerous.
So what did this one mean for you, Ali?
Well, it's really handy, isn't it, to have these GEMS somewhere easy to access for the various abnormal bloods. I've got them all stored on my desktop, and it's not just the hyperkalaemia we've got them for. We've got loads of them, hypercalcemia, hyponatremia, anemia, you name it. Actually, I think I said on the last podcast about I picked up a slightly serious clinical situation with a lady with hyponatremia by following our flowchart. So they are really useful. And it's worth mentioning as well, if you really want to get up to speed on all of your abnormal blood test results, there is our new Managing Blood Results in Primary Care course that's available on demand now.
Excellent. Yeah. And anything that can help me with my decision fatigue at the end of the day is very welcome. So all of this is great. So let's have a look at hyperkalaemia in a bit more detail. But before we get stuck in, it's just to say that we created this resource from a BMJ 2015 clinical practice guideline, a resource named Think Kidneys from the UK Kidney Association in 2023, and other sources. Full details in the written Pearl are there as always. So Ali, what are our first steps when we see a raised potassium?
So the management is going to depend on 4 things, and those are the degree of the hyperkalaemia, whether there's acute kidney injury or not, whether there are symptoms, and whether there are ECG changes.
Okay, so are you saying that we have to access an ECG machine to manage this scenario?
Well, it's tricky. The guidance we use to create this GEMS would suggest, yes, you do. But in real life, obviously, lots of us don't. I don't have acute access to ECG where I work at the moment. So it's difficult. I think you know, like in lots of these scenarios, you have to be pragmatic about the way you apply it. You have to use your clinical judgment. Maybe you have to have a slightly lower threshold for admission if you can't do that ECG and prove that it's normal. Yeah, difficult one.
Okay, but ideally, if you can, then do.
Yes.
Sorry, interrupted you there. Can you tell us how we would approach the management, please?
That's okay. Yes. So thinking about our most at-risk group first, the people who need admission, we should admit the person for inpatient treatment and cardiac monitoring if any of the following are true. And it's any one of these. It doesn't have to be in combination. So if they have severe hyperkalemia, which is defined as 6.5 millimoles per litre or more, if they are acutely unwell, if they have acute kidney injury with their hyperkalemia, or if their ECG shows any of bradycardia, diminished P waves, a long PR interval, a wide QRS, or peaked T waves. And that's because of the very important risk of VT or VF or arrest in hyperkalemia, or if the person has any symptoms of hyperkalemia.
So what symptoms will we be talking about there?
So we're looking for muscle weakness, paresthesia, palpitation, or syncope.
Okay, so that's people that we need to admit. So then thinking about the people that we can manage in primary care, who are they?
So we can look after the patient in the community if they have mild hyperkalemia, which is defined as 5.5 to 5.9 millimoles per litre, or moderate hyperkalemia, which is 6 to 6.4 millimoles per litre, as well as them having none of the things we just mentioned. So no ECG changes if you've been able to do an ECG, no AKI, no symptoms, and they're not acutely unwell.
Okay, and what does looking after them in the community involve?
So we're going to need to repeat their potassium. If they were in the mild category, we should do this within 3 days. And if their hyperkalemia is in the moderate category, we should do that repeat within 1 day. And we should also review the patient and their medications, making sure to reduce or stop causative drugs. And I'll give you more detail on what those causative drugs are in a minute. But Nick, what do you think some of the big culprits are? So
I would be thinking ACE inhibitors, ARBs, MRAs, they're important ones, aren't they?
Mm-hmm. Yeah. So your mineralocorticoid receptor agonists, your drugs like spironolactone, and the ACEs and the ARBs, yeah, that's it. So yes, and with those important categories, the specific instructions of what to do in hyperkalemia in the full Pearl, both acutely and once your potassium normalises. So I'm not going to go right into the details of that now, but just so you're aware, that information is there next time you need it. But yeah, that's the summary of how to manage hyperkalemia. So let's go a bit deeper now on causes of hyperkalemia.
Yes, and drugs are a big one, as we've already said. So ACE inhibitors, ARBs, spironolactone, eplerenone, they're all important here. But there are other causative drugs too, some obvious and some not so obvious. So potassium supplements, now that's an obvious one. That's obviously going to increase your potassium. Potassium-sparing diuretics, such as amiloride, non-steroidal anti-inflammatories, that can also put your potassium up. Macrogols, such as Laxidoo, Movicol, Cosmocol, all of those can do it. Non-selective beta blockers. Also trimethoprim or cotrimoxazole. And I know that whenever I've prescribed trimethoprim on my system at work, it will often flag up about sort of raised potassium as well. So it's one of those ones that, when you get kind of almost like word blind when it happens so much, but that's just a reminder that trimethoprim can cause that. Digoxin toxicity can cause it as well. Also, this is an important one to check with patients. Low salt in the diet or any kind of salt substitute which has got potassium chloride in it, that can obviously increase potassium as well. And then thinking of non-drug causes, so it could be a spurious result, such as delayed processing with the sample. It could be cold weather or sample taking problems, such as using a small needle or a clenched fist, extreme physical exercise or crush injury or hypothermia, which causes rhabdomyolysis. All of those could be implicated. Excessive dietary intake, such as fruit, vegetables and processed foods. And that's most significant if there is CKD.
Okay, so you mentioned renal impairment there, and we know that that's a risk factor for hyperkalemia. Can you remind us of the other risk factors?
So those include diabetes, heart failure, multimorbidity, and or serum bicarbonate of less than 25 millimoles per litre. But prevention, as with all these things, is better than cure, isn't it? So we're going to run through some ways that we can prevent hyperkalemia.
Yes, so the first is to prevent acute kidney injury from happening. And there's more detail on that in our AKI article. One really important action to take is withholding what we like to call at Red Whale the DAM drugs during intercurrent illness. DAM as in DAMN, or really it's DAM-GLYPH now because it's got glyphosines in as well. So that stands for D for diuretics, A for ACE ARBs, M for your MRAs, N for NSAIDs, and then, as we said, glyphosines. So one action point here might be to think about what education you're currently giving to patients when you start those drugs in terms of what to do when they become unwell. And then our second way to prevent hyperkalemia is to make sure we're doing adequate monitoring of our ACEs and ARBs and MRAs. So just to recap that, before starting an ACE or an ARB, you should check baseline UNEs, and you should exercise caution if you're starting them where there's a potassium of greater than 5 millimoles per litre. And then, as you probably know, we need to be checking UNEs 1 to 2 weeks after starting and after each dose titration. And then for your MRAs, again, you need to check your UNEs at baseline, and you should not start it at all if the potassium's greater than 5 or if the EGFR is less than 30. And then you'll be checking UNE 1 week after starting and 1 week after each dose titration, and then monthly for the first 3 months, and then 3 monthly for the first year, and then 4 monthly after that. And that's all in our article. If you're not going to hold it in your head, don't worry. And then maybe there's another action point there on looking at whether you're meeting those standards for everyone you've got on those drugs. And then thinking more broadly about UNE monitoring, if your patient's got CKD or heart failure or diabetes, according to the guidance we looked at, you should be monitoring their UNE 2 to 4 times per year because of the increased risk of hyperkalemia due to both the disease and the drugs. And then you also need to be monitoring UNEs more frequently if there's acute illness, previous AKI, or previous hyperkalemia. And we also need to be exerting caution, as we said, when prescribing trimethoprim if the person's already on ACE, ARB or MRA, or if there's any renal impairment.
It's tricky stuff, isn't it? So we mentioned in the GEMS that managing hyperkalemia in CKD can be a bit like a seesaw. Treatment of hyperkalemia or initiation of sick day rules often requires a pause or discontinuation of a preventative drug. Now, this in turn risks suboptimal treatment of heart or renal disease and increases the risk of CV events, hospitalisation, or even death.
Yeah, a very tricky balance. But I suppose to just bring it back to basics, just have a recap of our basic management, I thought we could finish off by talking through those 2 scenarios that we mentioned at the start. So thinking about how we would manage them with our flowchart in the GEMS. So this is my first case for you, Nick.
Okay.
We've got Geeta, she's 54. Her potassium is 6.1 on her annual review bloods. She's on candesartan for hypertension. She's not on any other drugs, and she's otherwise well. So should we have a quick look through our flowchart to see how we'd manage her?
Okay, so she would be classed as moderately hyperkalemic because she's 6.1, isn't she? So, and also these are routine review bloods. So we would need to check if she's got AKI, and she'd need admission if she had AKI or was acutely unwell. I would want to do an ECG acutely. Luckily, I have access to that at my surgery, so I'd do that. I'd also want to screen her for any of the symptoms of hyperkalemia. So does she have muscle weakness, paresthesia? Is she having palpitations, or is she feeling faint? Any of those would obviously need admission as well. If all of that is okay, then we could manage that situation in primary care. And obviously, to manage it in primary care, they need to be asymptomatic and well, and no acute AKI, and either mild or moderate hyperkalemia with a normal ECG. So therefore, as we said, moderately hyperkalemic, so 6.1. So you're going to repeat the U's and E's, and we're going to do that within a day. And then we're going to review the patient and her medication.
Brilliant. Top marks, Nick.
Okay?
You've got it.
Phew.
Yeah.
I was following the
Shall I
flowchart,
give
so it
you-
all worked.
There you go. I'll give you the next case. This one's a little bit less relaxing. So we've got Margaret. She's 84 and she had her UNE done on day 3 of a diarrhea and vomiting episode. She thinks she picked up a bit of a gastro bug from one of her grandchildren. She's having palpitations and she feels dizzy on standing, and her potassium is also 6.1.
Okay,
so what do we do for Margaret?
Yes, well, I can see that there are red flags everywhere with poor Margaret. So her potassium is also 6.1, so it's moderately raised, but she's having palpitations, she's feeling dizzy on standing, and she's not well on top of all of that. So therefore, that would suggest that we need to admit her.
And I suppose actually in that scenario, not having access to your ECG isn't the worst thing in the world, because it's not going to change your management.
Exactly, yeah, you're not going to change what you do.
Lovely. So shall we move on to our take-home messages for hyperkalemia?
Admit the patient to hospital if their potassium is 6.5 millimoles per litre or more, or if they have AKI, ECG changes or symptoms.
If the patient is safe to manage in the community, repeat their UNE within 1 to 3 days and review the patient and their medications.
Reduce or stop relevant drugs, including ACE inhibitors, ARBs or MRAs.
Prevent hyperkalemia by monitoring patients' UNEs appropriately and withholding risky drugs during intercurrent illness.
Excellent. So we've got the first pearl done. So Ali, how are you doing?
Yes, I'm doing well, thank you, Nick. It's been, I feel bad saying this, but it has been a bit too hot where I am recently, has it with you? I know we shouldn't complain. I'm not built. Yeah, I've got like Scottish and Irish heritage. I'm built to be in sort of cold, rainy, boggy weather. I'm not built to be in 30-degree heat.
I know what you mean, and I always, when it gets so hot, because we don't have air conditioning in our surgery, and I always make a point of saying this to the patients. So when they built this building, they told us we didn't need air conditioning because we could just have all the doors open. And you can't have the doors open in a doctor's surgery, can you? Because of confidentiality. So that ruins that argument. And so we just swelter every summer. Anyway.
I made a controversial fashion choice on Monday, Nick, to help with the weather. I went full scrubs and flip-flops.
Oh, cool. Okay. Well, I wore shorts. Don't tell anyone. But
oh. You've got to do what you've got to do, haven't you?
Exactly.
Oh, nice.
Okay, so shall we move on to our second pearl?
Let's do that.
Cool. So this is cancer, sexuality and gender. Now, June was Pride Month, and in honour of that, we're looking at the article, as I said, on cancer, sexuality and gender, and we're going to focus here on the ways that being LGBTQIA+ may affect cancer screening, diagnosis, treatments and holistic care, but we're also going to cover some strategies that are useful in providing sensitive and good quality healthcare to all LGBTQIA+ people. Now, this is a pretty long read, and it took me 28 minutes and 39 seconds, which is enough time for an iced latte, maybe, if it's hot weather. Ali, what did this one mean for you?
Yeah, so this pearl, I was part of the authoring team that wrote it, and I really enjoyed working on it. For me personally, it feels important now more than ever to do what we can to support the LGBTQIA+ community. And yes, as I say, this article was a team effort by several of us, including an expert reviewer that we got from outside Red Whale. And we credit them in the article, but I just wanted to mention them in the podcast as well. So big thanks to Dr. Dunks Shrewsbury, who helped us with this.
Excellent. So thank you for that. So we're going to talk about risk factors first. Now, some LGBTQIA+ people may have different risk factors for cancer compared with the rest of the population, and that can be useful to know, although, of course, every LGBTQIA+ person is different and will have their own individual risk profile, just as every straight or cis person is different. So looking at data from the Health Survey for England between 2011 and 2018, which collected information on both sexuality and health, some interesting stuff came up there, including that gay people have higher levels of harmful or potentially harmful alcohol intake and current smoking, but lower levels of obesity. They also have poorer mental health and higher levels of mental, behavioural or neurodevelopmental disorders. And all of that could potentially affect the types of cancer, the risk of cancer, the uptake of screening and health-seeking behaviours in that group.
It's worth stating as well, when we talk about risk factors for cancer in gay people, that we also know that men who have sex with men have higher rates of HPV, HIV, hepatitis B and C. And people who live with or have lived with those viruses have their risks of various cancers impacted by that, including hepatocellular, anal and cervical cancers. More details on there in the written pearl. And a side note here, going briefly off topic from cancer, because I've recently updated our HIV articles. If you want to get up to speed on HIV, do have a look at them. You can access them with your Redwell Knowledge subscription. And particularly if you don't know about PrEP or pre-exposure prophylaxis in HIV, it's really worth having a look, because that's a bit of a game changer in that area. And there's exciting stuff coming in, like annual, yearly injectable PrEP. So really interesting and important stuff to know about for some men who have sex with men and other LGBTQIA plus people. But coming back to cancer, which is what this pearl is about, thinking then about specific risk factors in trans people, a 2023 BJGP study found that in comparison with cisgendered people, trans men had higher prevalence of obesity and ever having smoked, and trans women had higher prevalence of dyslipidemia, diabetes, hepatitis B and C, and HIV, which again could impact cancer risk. Gender-affirming hormone therapy can also affect the risk of some cancers, and we're going to go into more detail on that later.
So thinking then about how being LGBTQIA plus can affect someone's access to healthcare, we look in the pearl at the concept of minority stress. This is a chronic and underlying fear about discrimination and prejudice that arises from stigmatised social or gender identity. We've taken that definition from the Psychology Bulletin back in 2003. And that fear is exacerbated by health systems being heteronormative, meaning that they're set up primarily to meet the needs of straight and cisgender people. The consequences of this are underreporting of risk factors for cancer, for example, smoking or alcohol intake due to anticipating judgment from health professionals, reluctance to present with cancer symptoms because of negative personal experiences with health services or experiences reported by others. Cancer awareness campaigns may be less effective at reaching LGBTQIA plus people due to the way that they're targeted. This can result in a lack of awareness of cancer warning signs or symptoms and confusion as to whether positive health interventions such as vaccination against HPV or screening are relevant for them. So, Ali, what can we do in primary care to support LGBTQIA plus patients in accessing care?
Well, we've collated the following advice from the GMC Ethical Hub on trans healthcare, the BMA guidance for managing patients with gender dysphoria, and Transactual, which is an organisation that supports trans patients and has a quick guide for doing that for GPs. And it's worth saying a lot of this advice isn't cancer specific. It's just about providing good care for this group of patients. So if appropriate, we should ask people about their sexuality, preferred pronouns and gender identity, with clear explanation of why this information is relevant. And with permission, we should clearly document that in an agreed location to avoid repeated questioning. We should code any gender-affirming treatment if possible, so that we don't miss associated risks. And we should make sure that staff are aware that patients may request to change the gender on their patient record at any time, and that they do not need to have undergone any form of gender reassignment treatment to do this. We should be aware of how out somebody is, so in what areas of their life are they open about their gender identity or sexuality, and be particularly mindful of confidentiality when contacting our patients by writing or telephone and in person. Keeping in mind that under the Gender Recognition Act 2004, it's an offence to share someone's transgender status unless that information is relevant to their care. We should make sure our surgeries are as LGBTQIA plus inclusive as possible. This might be via staff education, inclusive health information in the waiting room and on the website, and making sure all staff appreciate the importance of the use of preferred pronouns and names. And we should avoid misattributing other health problems to gender or sexuality, so that's known as diagnostic overshadowing. So obviously, while sexuality and gender are relevant to some presentations, we definitely shouldn't make every consultation with the person about that. We should support smear takers in the practice to access additional training around cervical screening in LGBTQIA plus people, remembering, for example, that gay women might not know that they're still at risk of HPV and are still recommended to have cervical screening, and that there are complex challenges associated with trans men and smears. More on that later. And because patients will only be invited for screening relevant to their registered gender, we should ensure that we have systems in place to add or remove trans patients from national screening recall systems as appropriate. Again, more detail coming up on that. And we should advertise and promote organisations such as Outpatients and Macmillan Cancer Support to our patients. For people reluctant to consider screening or worried about cancer, these can be a great source of information and support. And we should also be aware that an LGBTQIA+ person's chosen family and biological family may differ, and we should include those who are important to the patient as appropriate.
Now, we're going to focus on trans people for a while now and think about how gender-affirming treatments may impact screening for and presentations of cancers. Before we get stuck in, we're going to look for a moment at what it means to be trans, recognising that you might have lots of understanding and experience in this area, but you also might not, and that's okay. Gender identity can be fluid over time or circumstance. In most definitions, the term trans relates to people whose gender identity doesn't align with their birth-assigned sex and includes transgender men and women, non-binary people, and gender fluid or gender queer people. The NHS guidance on inclusive content defines trans as an umbrella term to describe people whose current gender identity or way of expressing their gender differs from the sex that they were registered with at birth. Some, but not all, trans people want to transition or change socially or medically or both. Practically, this means that trans people may have socially transitioned, which may involve changing their name and appearance, have undergone gender-affirming surgery, be on gender-affirming hormone therapy, GAHT, with or without intention to have surgery, or not be on GAHT or had gender-affirming surgery. So, Ali, can you give us some of the headlines on how GAHT might affect our patients in terms of cancer risk?
I certainly can. And one thing to bear in mind as we work through these is that trans people don't always access their hormones through the NHS. So we might not know that they're on this treatment unless we ask. And we shouldn't assume that any necessary monitoring has been organised by secondary care. For trans women, so we're talking here about people assigned male at birth, exogenous estrogen may increase their breast cancer risk. They may need breast screening, and we should be aware that this will only happen if their registered gender is changed. Estrogen can also reduce PSA levels, so if a trans woman presents with lower urinary tract symptoms, we should be aware of the risk of prostate cancer, and we should bear in mind that PSA samples require additional labelling of gender assigned at birth and hormone therapy used, and normal ranges will be affected, so we need to be really careful about both requesting the PSA and reviewing the result correctly, and there'll be more details on that in a minute. And then finally, it's worth noting that trans women will not need cervical screening, but will be invited for this if they change their registered gender. And then thinking about trans men, with a reminder that these are people assigned female at birth. Exogenous testosterone can increase the risk of endometrial cancer. And if they've been on testosterone for more than 2 years, they should have ultrasound surveillance and prompt assessment of any symptoms. Cervical screening invites may stop if they change registered gender, but they still need screening if they have a cervix. Coding can help identify that issue. And trans men may not need breast screening if they've had top surgery, meaning removal of breast tissue, but they should consider breast screening if they have breast tissue. This needs an individual discussion and a plan made on a case-by-case basis.
And as we've just alluded to, patients will only be invited for cancer screening according to their registered gender, which may result in missed screening or invitations for inappropriate screening. In primary care, we'll need to be alert to this and support our patients to access the screening they need. 2 codes are provided to help in searches for these groups: the Gender Identity Code and the Gender Same at Birth Indicator Code. Colleagues at the Sussex Gender Service have told us that they recommend that practices consider developing an in-house transient database to support them in the recall for these patients. So this would only be active whilst necessary for good patient care. Now we're going to go into a bit more detail now and look at specific considerations for cervical, breast and prostate screening in trans people. Thinking first about cervical screening. If you're sending a smear sample for a person registered as male, it's vital to inform the laboratory that the patient does have a cervix because the sample may otherwise be rejected. The website Outpatients has some excellent resources for trans men and non-binary people to support them to attend cervical screening, and you can have a look at the useful resources section at the end of this article. In some cities, including London, Brighton and Glasgow, specialist clinics have been set up, usually as part of sexual health services. People can arrange to attend these services even if they don't live in those areas, and there are links to those in the show notes as well. And those taking testosterone may experience vaginal atrophy, and this can increase discomfort. And we've heard from colleagues working in this area, and they've suggested that using topical vaginal estrogen for 2 to 4 weeks prior to cervical screening can be helpful. And as we know from its use in other patient populations, it's not systemically absorbed, i.e. it's safe for transgender men and non-binary people to use without feminizing effects.
And then thinking about special considerations for breast screening. It's important to remember that gender diverse people may prefer the terminology chest to breasts, so we should ask about that or follow the person's lead. And as we said already, trans women treated with estrogens will be at higher risk of breast cancer than cisgender men. That comes from the gov.uk document on NHS population screening information for trans and non-binary people. And trans men who have any breast tissue should be invited for mammography, but will not be routinely invited by the National Screening Programme if they're now registered as male with their GP. Trans men who have not had top surgery meaning mastectomy and sculpting of the chest wall, should be referred by their GP practice to the breast screening service with their agreement. They can directly contact the service to request appropriate appointment scheduling and awareness on the part of the screening team to avoid any unnecessary distress and embarrassment. If mammography screening is not possible, the patient should be advised to continue self-checking. And for those who have had top surgery, as we've already said, the need to continue with breast screening will depend on the volume of breast tissue left, and this should have been specifically discussed with them actually by their surgeon, and then it's useful if we can document this in the medical record.
And finally, thinking about screening for prostate cancer and taking PSAs in trans women, the risk of prostate cancer is the same for trans women as cis men if they are not on gender-affirming hormone therapy and they have not had gender-affirming surgery, for example, orchidectomy. The risk in trans women who've started GAHT or had gender-affirming surgery is a little less than age-matched cis male controls, but it may be more tricky to spot. So here are some tips from the BJU International, and that's from 2022. We shouldn't forget the possibility of a prostate malignancy. We should consider it in those with urinary symptoms that can be misattributed as UTIs. Digital rectal prostate examination may not be possible. In gender reassignment surgery, the prostate gland is not removed due to the risk of damage to adjacent structures, so trans women will almost always still have a prostate. But if a vaginoplasty has been performed, the prostate can only be palpated via the anterior neovaginal wall, so identifying malignancy on examination may not be possible in primary care. We should ensure that the PSA test form states that the person was AMAB, so assigned male at birth. Some laboratories will refuse to process a PSA blood test for a patient registered as female. We should advise to avoid receptive anal sex for 1 week prior to a PSA test to avoid false positives. Although there is no formal guidance in this area, personal communication from colleagues working in this area tells us that it's advisable to avoid neovaginal penetrative intercourse for this same period due to the position of the prostate post-vaginoplasty. Expert consensus is that the upper limit for a normal PSA for this group should be set at 1 nanogram per mil. Now, we may need to seek advice and guidance or speak to colleagues in secondary care to help people navigate the suspected cancer pathway in this situation where a PSA may be more than 1 nanogram per mil but not reach the official referral criteria. And that again is from BJU International from 2022. We also need to be careful that we don't unwittingly file a PSA flagged by the lab as normal when it is in fact abnormal for our trans patient. So might this be a useful action point to share with your colleagues?
Okay, so we're moving back to thinking about LGBTQIA plus people as a whole now, rather than just trans people. And we're going to think about life after cancer, including sex. A report by Macmillan found that LGBTQIA plus people can have uniquely difficult experiences during their cancer journeys. They reported being less likely to feel that they had been told about their diagnosis sensitively and less likely to believe they were being treated with dignity and respect by staff. There were reported episodes of misgendering, unintentional outing of patients to friends and family, and partners being mistitled as a friend or even a sibling rather than a recognition of their relationship with the patient. So, after cancer, we might be supporting the patient as they recover both from the trauma of their diagnosis, but also potentially trauma associated with negative healthcare experiences as well.
Thinking specifically about sex and intimacy, many cancer patients, not just LGBTQIA plus people, struggle with the psychosexual impacts of cancer diagnosis and treatment. Their body image, energy levels and libido are commonly affected. They may blame themselves for their cancer or struggle with returning to normal life because of the cancer and its treatment. For LGBTQIA plus people, these issues can be compounded by other difficulties, for example, internalized stigma, a potential lack of family support, and the potential impact of this diagnosis on plans around GAHT or gender-affirming surgery. Patients may not mention difficulties with sex due to embarrassment, a fear of being judged, or just because it isn't seen as medical, in inverted commas. As clinicians, we may also be less sure what services and support we can access. For LGBTQIA plus people, this can mean that someone's gender identity or sexuality is ignored or not appreciated, and the advice that they are given may be skewed towards the heteronormative. One example of where cancer treatment can impact on LGBTQIA plus people is the treatment of prostate cancer, where issues around abstention from receptive anal sex for a period post-treatment may be particularly important to some patients, on top of the other sexual health concerns any prostate cancer patient may face, such as erectile dysfunction and retrograde ejaculation.
There are very few studies around trans patients and cancer, including very little on the effect of radiotherapy treatment on the neovagina in trans women. One example of where sexuality can impact body identity is breast reconstruction after breast cancer treatment. So there's some evidence from a systematic review and from Macmillan-funded survey data that gay and bisexual women report feeling pushed towards considering breast reconstruction by their medical teams, whereas they expressed feeling less focused on the appearance of the breast and more focused on breast sensation and sensitivity. And really importantly, trans patients may be advised to stop using or to delay starting gender-affirming hormone or surgical treatments during diagnosis and active treatment of cancer. And this can cause significant distress, and some patients may even refuse to accept treatments that could impair their transition. A great organisation to signpost to is the UK Cancer and Transition Service, who accepts self-referral from patients across the UK with cancer or a history of cancer where they feel it impacts on their gender-affirming care. So here are our take-home messages for cancer, sexuality and gender. Sexuality and gender identity can potentially impact on all stages of someone's cancer journey, and we can support them by providing inclusive and informed care.
LGBTQIA plus people have higher rates of some cancer risk factors, such as smoking and alcohol consumption, and report experiencing discrimination in accessing cancer care.
Trans people may need our help to ensure they are accessing appropriate screening programmes.
Gender-affirming treatments can affect presentations and testing for some cancers.
And if you'd like some more updates around cancer, then our online cancer course is available on demand now.
And from our pride-related pearl to people we're proud of in primary care, here are our superheroes.
So I have an email here. It says, "Dear Red Whale Pod team, firstly, just want to say how much I enjoy the podcast and how much it contributes to my CPD. The topics discussed are relevant and interesting, and I'm often discussing the information gleaned in our practice meetings, so thank you." Well, thank you for that. It says one of the things that I particularly like is the commitment to shared decision making. You often make reference to how the information you present can be used to support shared decision making in practice. And that's from Sam. We really appreciate that, Sam.
Yes, thank you, Sam. And Sam's also made a great suggestion for a future episode in Pearl, and we've passed that on to our wider editorial team. So thanks for that. And also we had another email. This is from Alice, and she says hello to Fiona and to Ali and to myself. And she said she's been enjoying the Red Whale podcast as always. So thank you for that, Alice.
So it's been really popular, our trainee package, hasn't it?
Yeah, so the GP Trainee Essential Support Package. Now, this is exclusively available to GP ST MDU members and affiliates. So if you are one of those, then it's free and it's worth £165, and it's designed to build your knowledge and confidence and help you pass your exams. And so what's included, I hear you ask? Well, it's really helpful because it's got Red Whale Knowledge Access, which is over 900 written resources to support you during consultations and also with your CPD. And also the Top AKT Topics Digital Handbook, which covers areas that trainees struggle with most, and webinars throughout the training year to support you with your exam preparation. So if you click on the link, then you can sign up for that.
And some terms and conditions. The package is completely free for MDU affiliate and GPST members, but MDU GPST membership itself does carry a charge to sign up. Our GP Trainees Essentials package is a free benefit of affiliate and GPST MDU membership. In terms of affiliate membership, if you're a GP trainee in England, you can sign up for a free MDU affiliate membership anytime during your training. And in terms of GPST membership, if you're a GP trainee in Scotland, Northern Ireland or Wales, you can sign up for GP Trainee Essentials free when you become an MDU GPST member. Once you're signed up, you'll receive a code from the MDU so you can get GP Trainee Essentials as a free member benefit.
Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale pod members. And how do you become a member, I hear you ask? Well, if you're listening to us, then you are part of our pod. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get 10% off. And here's the small print. The discount is only for this product and won't work on anything else. And please also note that this voucher code is all one word and all lowercase, RedWhalePod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we would really appreciate it. If you can spare a little more time, then please leave us a nice review. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms aside, there's no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want us to see something about the podcast, then please use #RedWhalePod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Bye.